When I was in my first year of pediatric critical care fellowship, I remember admitting an adolescent girl to the PICU for treatment of acetaminophen toxicity. This was back when the intravenous form of the antidote, a medication called N-acetylcysteine, or NAC for short, was not as readily available as it is now. So it was standard practice to prescribe the oral formulation and to reserve the IV formulation for patients who could not safely swallow the medication. The oral receives a loading dose. They must drink a smaller dose every 4 hours for an additional 17 doses over 72 hours. And it's not that they have to drink the stuff every 4 hours. NAC smells like rotten eggs. It has a component of sulfur, and it is noxious. And so it needs to be diluted, and typically the drink of choice is some sort of caffeine-free diet soda. But even if you do this, it just barely masks the smell. And even though the dose, again, may only be 1 to 2 ounces of the NAC, it is just really difficult to get down. Unfortunately, any doses that need to be vomited have to be repeated. So I'm admitting this girl. There's truly no excuse for my behavior. I do remember I was on call because my patient's nurse, Holly, was working nights then. And so after I finished ordering up the follow-up doses, Holly mentioned that after drinking the first dose, our patient asked whether she had to take all 17 follow-up doses. Holly said she had a really hard time getting that first dose down. I didn't have much sympathy. Well, I replied, does she want liver failure? She needs to understand that if she doesn't drink all the doses, we'll just put an NG tube down and she'll get the NAC that way. And then I added the kicker, maybe she'll learn her lesson and not do this again. Holly looked at me. Oh, Grace, she said very gently. I can still see her expression. Our girl's had a really, really hard day. Possibly one of the worst days of her life. Holly said, imagine feeling like there's no way out other than suicide, and then having to be hospitalized and drink medicine that smells like rotten eggs. I don't think we need to make her life more miserable. I instantly felt a sense of shame. Why was I being so mean? Now, I'm sharing this story this morning because I want to use my experience to explore the issue of shame in medicine. And before I proceed, please know that our patient ultimately tolerated all of her oral doses of NAC. She did not sustain any permanent liver damage. And Holly, I am pleased to say, continues to be an excellent and compassionate advocate for her patients. I still work with her. But returning to the exploration of shame in medicine. Well, first, we'll go back to our definition of shame. Then we'll discuss how shame can influence professional identity formation and medical training, and how it can impact the patient-physician relationship. And lastly, I'll conclude with suggestions for contextualizing shame, but honestly, we have Dr. Scott who's going to come and really fill us in with much more authority than I ever can. But before I dive in, I should note that I'm discussing this from my perspective as a physician. However, I believe that the experience of shame is not limited to doctors, and that the findings and observations of shame from the practice of medicine are transferable to other specialties. So first, what is shame? As Dr. Garner has so eloquently helped us to understand, it's a self-assessment that one has failed to live up to one's personal values. Shame is that feeling that arises from a negative outcome that is due to a fundamentally flawed self. And again, shame is different from guilt. Guilt relates to a specific action. Shame pertains to one's entire self. So after this experience, I actually spent a bit of time trying to determine whether this negative emotion I felt sweep over me, whether that was guilt or whether it was shame. It was shame, because I feared that my words revealed a deficiency in my identity and demeanor as a physician. In other words, I was very far from the ideal I aspired to be. So what do we do with these uncomfortable feelings? especially when we suddenly realize that our whole self, not just a part of us, but our whole self can be lacking. And I think it's helpful here to delve into the concept of professional identity formation for some understanding. Professional identity formation is this ongoing process and journey of integration of professional qualities, knowledge, skills, values, and behaviors into one's personal identity. The result of this process is a person who acts and feels like a physician. Now, professional identity formation is socially constructed. People aren't born with an innate sense of how to be a physician. We learn how to be a physician through integrating relational learning with our past experiences. We absorb the core values of medicine through acculturation. We are given an understanding of how to behave, though we do so in a hierarchical environment marked by asymmetric power. For example, clinician to patient, attending physician to student, etc. So within this context, shame becomes a powerful emotion. Now, shame isn't all good or all bad. There's positive as well as negative aspects of shame. So here are a couple of the positive aspects of shame. It can aid in the development of one's moral compass. Shame makes us aware that our reality does not match our moral ideals, especially if these moral ideals are essential to maintaining our professional identity. My shame did not come from the inherent wrongness of my expressed sentiment that my patient needed to learn from the natural consequences of her action. No, rather, my shame originated from falling short of the moral virtues that are crucial to my identity as a physician. And I think this distinction is really important because the proper role of shame is highly contextual. The sentiment that I expressed may have been okay coming from the friend of a patient, but it certainly wasn't okay coming from me in my role as her physician. Another positive aspect of shame is that it can effectively inculcate pro-social behavior, especially in a hierarchical environment. So the experience of shame can act as a commitment device towards altruism. In other words, it can drive people towards good behavior. This is very powerful. I can tell you from firsthand experience because I always paid a bit more attention to my behavior whenever I worked with Holly. Not that Holly is grading me, but I want to be the type of physician that is worthy to care for her patients. So while shame can lead to positive outcomes, it can also be damaging, especially regarding emotional self-regulation. The hit to one's self-perception can be so destabilizing that it causes a person to develop maladaptive behaviors to escape the discomfort that comes with feeling shame. These behaviors can include withdrawal from activities, emotional suppression, even addiction. Additionally, it's crucial to note that healthcare is often, again, balanced or it's often practiced in a hierarchical environment that is filled with power imbalances. One's position in the hierarchy can significantly influence not only how one perceives shame, but also how shame is processed. Now, Holly was an experienced nurse. I was a new physician. How might this decision have been different, or this experience, how might my experience have been different if this had been Holly's first year as a PICU nurse, or if I had been an attending physician rather than a first-year fellow? Because of everything that I've just mentioned, shame can significantly impact those undergoing medical training. So we've just discussed how shame can aid in the development of one's moral compass, or it can lead the trainee towards maladaptive behaviors. Shame can assist in developing emotional regulation, or it can drive a trainee towards emotional withdrawal and isolation. Shame can be a tool that encourages altruistic and pro-social behavior, or it can suggest to the trainee that the best way to avoid shame is to be perfect, or, because nobody's perfect, to keep up and present an illusion of perfection. So what tips the balance between how we process and how we experience shame? Well, thank God we have Dr. Scott to help us navigate through these tough questions. So I'm going to punt that football over to him. But I can't help but reflect on the social nature of healthcare and how much this has to do with how we experience shame. I want to step back a little bit and just say that much of what I've learned about caring for patients hasn't been given to me or taught to me through a textbook, but it's been absorbed. I've absorbed it from the people around me. The physicians who influenced me most didn't lecture me on how to be a virtuous physician. I literally soaked it up through my pores, through my daily interactions, as I observed them caring for patients. I see some of my teachers here today, and for this, I truly want to say thank you. In medicine, we call this the hidden curriculum. It's the implicit messages, the norms, the values, the attitudes that, while often unarticulated, are nevertheless accepted wholly, and even more concerning, unexplored. In fact, many medical educators consider the hidden curriculum to be more powerful than the formal curriculum in shaping professional identity. And so it is sobering to realize that because of the social nature of medicine, shame may be felt by the individual, but it is shaped by the community. I can't remember who was around Holly and I when we discussed our patient, but I know that we weren't alone. So I wonder what implicit messages were absorbed by those around us that night. Did our interaction emphasize the importance of certain values over others? Did our behavior highlight a certain way of being? Or did this experience contradict the staff's formal teaching on issues like professionalism or ethics? I also wonder about this. We were in a pediatric unit. Would I have felt shame in a different clinical environment? Shame is such a collective emotion. It's humbling to realize that we all play a small role in shaping an environment that it is either conducive or detrimental to the development and the processing of shame. So, we've spent a bit of time on the experience of shame felt by clinicians. How do patients perceive shame in medicine? How does this affect the patient-physician relationship? Well, shame can arise from various factors, including the symptoms experienced by the patient, right? Their physical or psychological exposure in the clinical setting, and the broader societal stigmas. In fact, there's echoes of what Dr. Garner described to us from Job. And at times, it seems that the very words that we use in medicine can induce shame, not due to the words themselves, but the societal values attached to them. For example, if you were a patient, which diagnosis would you prefer to have announced by the intern who's presenting your case during rounds to a group of 10 or 15 strangers? Alcoholic liver cirrhosis or cirrhosis secondary to Wilson's disease, a rare inherited condition whose symptoms may not manifest until adolescence? For patients, these are not the only sources of shame. It could be the anticipation of being judged and found wanting by the only people with the power to help you. It could be that you must expose the areas of your body that are disfigured and scarred. It could be that you do not fit the expectations of what a person who has the disease should behave like. Or it could be that you've shared your concerns in a way that left you vulnerable, but your concerns were not addressed. Whatever the source of shame, unacknowledged shame can damage the patient-physician relationship, hinder communication, and perhaps lead to an inaccurate diagnosis and inadequate treatment. Patients may avoid healthcare altogether, delaying necessary care. But it's not just the patients. Physicians also feel the consequences of unrecognized or unacknowledged shame. Researchers studying medical students and resident physicians have shown that shame is associated with decreased empathy, burnout, depression, and isolation. As my time draws to a close, I want us to consider the impact of power dynamics on the experience of shame. There's a difference between shame as an emotion and shaming as an action. Shaming involves a power dynamic with somebody in a position of authority or influence who uses shame to enforce compliance, maintain control, or assert dominance. In my experience with my patient, I believe this was at the core of my shame. I already had an unimaginable amount of control over her body and her being. She was in a place where she couldn't leave. She was being constantly monitored by a sitter. She couldn't even go to the bathroom alone. Every single bodily fluid that came out of her was going to be measured and reported. She couldn't go anywhere outside of her room. Of course she didn't want to drink this nasty medicine. So why did I threaten to put the NG tube in? To save her liver? No. It was a way to assert a kind of malign dominance, to try to shame her, to make her feel less than because of a decision that had been made in a desperate moment in her life. This is not to deny the reality of the situation, but more to say that I felt shame because that was not my place to do that. So what should we do when we feel shame? First, let's acknowledge that shame is multifaceted. It's shaped by social interactions and individuals' experience, the environment where it's experienced. And because of its unique hierarchical structure and many power imbalances, the experience of shame in medicine, I believe, is different than in other contexts. Next, the two powerful antidotes to shame are self-compassion and empathy from others. Self-compassion acknowledges the errors encountered on the journey towards moral ideal. Empathy and understanding from others shield us from the negative effects of shame, such as the breakdown of our self-perception. And lastly, we all have a responsibility to be aware of whether shame or shaming is taking place and to mitigate the negative aspects of unreasonable shame. This is difficult, but an area that I believe we all can work on. Over the years of my practice, I've experienced both positive and negative aspects of shame in medicine. I've been incredibly fortunate to work alongside people who have shaped and sharpened my moral compass. But I've also struggled with perfectionism, fear of being exposed, where my actions were driven more of a desire to avoid feeling shame rather than doing what is best for my patient. I'd have to admit, it's a little uncomfortable sharing all of this. But I've done so this morning because I believe at the heart of it, this experiential knowledge that I've gained by feeling shame, by exploring its roots, makes me fundamentally a better physician. Emotions such as shame are powerful tools for learning and formation in healthcare. And I invite you this morning and later on to a deeper exploration of emotions in your own life. Thank you.